Welcome to Topics Explained, the M3 Clerkship series. Today we're doing a comprehensive deep dive into bilirubin metabolism and jaundice physiology. Quick note, if you're short on time or just want the high-yield version, we have a shorter quick review video linked in the description and in the card above. That one covers the essentials in about 6 minutes. But if you want the full picture, the biochemistry, the inherited syndromes, the clinical reasoning, stick with this one. Whether you're heading into your medicine or surgery rotation or sitting down to study for shelf exams, this is one of those foundational topics that ties normal physiology directly to clinical reasoning. By the end of this video, you'll understand exactly how bilirubin is made, how the liver processes it, what happens when things go wrong, and most importantly, how to build a differential for the jaundice patient on your wards. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. So let's start with why this matters. Bilirubin is the end product of heme degradation, and jaundice, that yellow discolorations of the skin and sclerae, becomes visible when bilirubin rises above about 2.5 milligrams per deciliter. The earliest sign is scleral icterus, and it's something you'll be expected to pick up on physical exam. The framework for jaundice is beautifully simple and mirrors how you think about acute kidney injury: prehepatic, hepatic, and posthepatic. Understanding bilirubin metabolism is the key that unlocks that entire framework. Here's our roadmap. We'll trace bilirubin from its origin and heme breakdown, through the liver's 4-step processing system, out into the gut via enterohepatic circulation, and then we'll apply all of that physiology to the 3 categories of jaundice and the inherited hyperbilirubinemias. Let's start at the very beginning. Where does bilirubin come from? About 70 to 90% comes from the breakdown of hemoglobin in senescent red blood cells, the ones that have reached the end of their 120-day lifespan. The remaining 10 to 30% comes from other hemoproteins, myoglobin, cytochromes, and from ineffective erythropoiesis in the bone marrow. The entire process begins in the reticuloendothelial system, primarily macrophages of the spleen and liver. Heme oxygenase cleaves the porphyrin ring of heme, producing biliverdin, carbon monoxide, and iron. Then biliverdin reductase converts biliverdin into bilirubin. Now here's the critical point. This unconjugated bilirubin is water insoluble. It has tight internal hydrogen bonds that hide its polar groups, so it must bind to albumin for transport through the blood. Because it's albumin-bound and lipid-soluble, it cannot be filtered by the glomerulus, which means unconjugated bilirubin never appears in the urine. That's a board pearl you need to lock in right now. But that same lipid solubility is what makes it dangerous. It can cross the blood-brain barrier, especially in neonates, leading to kernicterus. Now let's follow that albumin-bound unconjugated bilirubin as it arrives at the liver. Hepatic processing involves 4 distinct steps, and understanding each one helps you pinpoint exactly where things can go wrong. Step 1 is uptake. Bilirubin separates from albumin and enters the hepatocyte through carrier-mediated transport involving proteins like OATP1B1 and OATP1B3. Step 2 is intracellular binding. Inside the hepatocyte, bilirubin binds to glutathione S transferases, historically called ligandins, which keep it in solution and prevent it from leaking back out. Step 3 is conjugation. This is where the magic happens. The enzyme UGT1A1, or uridine diphosphate glucuranosyl transferase, attaches 1 or 2 glucuronic acid molecules to bilirubin, creating bilirubin monoglucuronide and diglucuronide. This disrupts those internal hydrogen bonds and makes the molecule water-soluble. And step 4 is excretion into the bile canaliculus via MRP2, an energy-dependent transporter. Here's something that catches a lot of students off guard. The rate-limiting step in bilirubin metabolism is not conjugation, it's excretion via MRP2. That's why even moderate liver disease can cause conjugated hyperbilirubinemia before conjugation is significantly impaired. Once conjugated bilirubin is excreted into bile, it drains into the duodenum and passes unchanged through the proximal small bowel. It's too polar and hydrophilic to be reabsorbed by intestinal mucosa. When it reaches the distal ileum and colon, bacterial beta-glucuronidases hydrolyze it back to unconjugated bilirubin, which is then reduced by gut flora into a group of colorless compounds called urobilinogens. About 80 to 90% of these products are excreted in feces where they're oxidized to urobilins. That's what gives stool its brown color. The remaining 10 to 20% of urobilinogen is reabsorbed into the portal circulation and undergoes enterohepatic cycling, getting taken up by hepatocytes and re-excreted into bile. Only a tiny fraction escapes hepatic reuptake and reaches the systemic circulation, where it's filtered by the kidneys, and that's what makes urine yellow. Now, connect this physiology to the bedside. If no bilirubin reaches the gut, there's no urobilinogen production, which means pale stool and no urinary urobilinogen, classic for obstruction. If there's massive hemolysis, excess conjugated bilirubin floods the gut, producing excess urobilinogen, which gets reabsorbed and darkens the urine. And here's the keyboard pearl. That dark urine in hemolysis is from increased urobilinogen, not from unconjugated bilirubin, because unconjugated bilirubin simply cannot enter the urine. If you're finding this helpful, please like, subscribe, and hit the notification bell so you don't miss future videos in this series. Now let's apply everything we've built to prehepatic jaundice. The classic scenario is hemolytic anemia, sickle cell disease, hereditary spherocytosis, G6PD deficiency, autoimmune hemolysis. Excess red blood cell destruction overwhelms the liver's conjugating capacity, leading to elevated unconjugated bilirubin. On labs, the direct fraction will be less than 15% of total. Urine will be dark, but remember, that's from excess urobilinogen reaching the kidneys, not from bilirubin itself. Urine dipstick for bilirubin will be negative. Stool is normal to dark because more bilirubin is reaching the gut. One critical number to remember, hemolysis alone typically cannot sustain a bilirubin above 4 mg per deciliter because the bone marrow can only increase erythrocyte production about 8-fold. So if you see a bilirubin of 15 in a hemolytic patient, suspect concurrent liver dysfunction. The classic complication is pigmented calcium bilirubinate gallstones from the chronically increased bilirubin load. Hepatic jaundice has two main patterns, and distinguishing them is key to your workup. Hepatocellular injury, think viral hepatitis, drug toxicity, alcoholic hepatitis, Wilson disease, damages both the hepatocytes and the small bile ductules. This impairs conjugation and excretion simultaneously, so you get a mixed picture with both unconjugated and conjugated bilirubin elevated. The signature lab pattern is markedly elevated aminotransferases, AST and ALT, often in the hundreds to thousands with viral or toxin-mediated injury. In alcoholic hepatitis, look for the classic AST to ALT ratio of at least 2:1, with AST rarely exceeding 300. Urine is dark from conjugated bilirubin leaking into the blood and being filtered, but urobilinogen is normal or decreased because less bilirubin is making it into the gut. The second hepatic pattern is enterohepatic cholestasis, where bile flow is impaired within the liver itself. The lab signature here is elevated alkaline phosphatase and GGT out of proportion to the aminotransferases. Causes include primary biliary cholangitis, primary sclerosing cholangitis, drug-induced cholestasis, and cholestasis of pregnancy. The key imaging finding: ultrasound shows no dilated bile ducts, which distinguishes enterohepatic from extrahepatic obstruction. Posthepatic jaundice means something is physically blocking the bile duct. The most common cause is choledocholithiasis, a gallstone impacted in the common bile duct. Other causes include pancreatic head carcinoma, cholangiocarcinoma, and strictures. When bile can't flow, everything in it backs up into the blood. Conjugated bilirubin rises and spills into the urine, making it dark and positive on dipstick. Bile salts deposit in the skin, causing pruritus. Cholesterol backs up, causing hypercholesterolemia and sometimes xanthomas. And because no bilirubin reaches the gut, stool becomes pale or clay-colored, and urobilinogen disappears from the urine. Patients also develop steatorrhea and malabsorption of fat-soluble vitamins A, D, E, and K because bile salts aren't available to emulsify fat. The first test to order is a right upper quadrant ultrasound. Dilated intrahepatic or extrahepatic bile ducts confirm mechanical obstruction. If pancreatic head carcinoma is causing painless jaundice, you may find a palpable, non-tender gallbladder that's Courvoisier sign. Now let's cover the inherited hyperbilirubinemias because they're guarantee board material. Gilbert syndrome is the most common by far, affecting 3 to 7% of the population. It's caused by a mild reduction in UGT1A1 activity, typically 10 to 35% of normal. Bilirubin is usually below 6 mg per deciliter and only becomes noticeable during fasting, stress, or illness. It's completely benign and requires no treatment. Crigler-Najjar type 1 is the opposite extreme, complete absence of UGT1A1. These neonates present with bilirubin levels of 20 to 45 mg per deciliter, severe kernicterus risk, and do not respond to phenobarbital. Liver transplant is the only definitive treatment. Crigler-Najjar type 2 has severely reduced but not absent UGT1A1. These patients survive to adulthood with bilirubin of 6 to 25 mg per deciliter and do respond to phenobarbital, which induces whatever residual enzyme activity remains. On the conjugated side, Dubin-Johnson syndrome is caused by mutations in MRP2, the canalicular transporter. The board buzzword is a grossly black liver from melanin-like pigment deposition. Rotor syndrome is similar but involves deficiency of the reuptake transporters OATP1B1 and OATP1B3, and critically, the liver is not discolored. Both are benign. Before we move to the clinical workup, let's talk about neonatal jaundice because it's a special and extremely high-yield case. Newborns are uniquely vulnerable to unconjugated hyperbilirubinemia for several reasons. UGT1A1 activity is low at birth, canalicular excretion mechanisms are immature, red blood cell turnover is higher because fetal red cells have a shorter lifespan, and enterohepatic recirculation is increased. Physiologic jaundice typically appears on day 2 or 3, peaks around day 3 to 5, and resolves by day 7 to 10 in term infants. Red flags that suggest pathologic jaundice include onset before 24 hours, which should immediately make you think hemolysis, bilirubin rising faster than 5 mg per deciliter per day, total bilirubin above 12, or jaundice persisting beyond 2 weeks. The feared complication is kernicterus. Unconjugated bilirubin crosses the immature blood-brain barrier and deposits in the basal ganglia, causing irreversible neurologic damage or death, typically at levels above 20 to 25 mg per deciliter in term neonates. Treatment is phototherapy, and here's a critical board point: phototherapy does not conjugate bilirubin. It converts unconjugated bilirubin into water-soluble photoisomers that can be excreted directly in bile and urine without conjugation. For severe cases unresponsive to phototherapy, exchange transfusion is the next step. So let's put it all together with a practical approach to the jaundice patient. Step 1. Get a total and direct bilirubin. If the direct fraction is less than 15%, you're dealing with unconjugated hyperbilirubinemia. Check for hemolysis with a reticulocyte count, LDH, haptoglobin, and peripheral smear. If hemolysis is present, identify the cause. If hemolysis is absent in an otherwise healthy patient with mild elevation, that's Gilbert syndrome, and no further workup is needed. If the direct fraction is elevated, you have conjugated hyperbilirubinemia, and you need to determine the liver injury pattern. A hepatocellular pattern with markedly elevated aminotransferases points you toward viral serologies, drug history, autoimmune markers, and ceruloplasmin. A cholestatic pattern with elevated alkaline phosphatase and GGT should prompt an ultrasound. Dilated ducts mean extrahepatic obstruction requiring MRCP or ERCP, while no dilation means intrahepatic cholestasis requiring serologic workup and possibly biopsy. One quick bedside screen that's easy to forget. A urine dipstick positive for bilirubin immediately tells you this is conjugated hyperbilirubinemia, because unconjugated bilirubin can never appear in urine. Let's wrap up with a high-yield comparison. In prehepatic jaundice, unconjugated bilirubin rises, urine is dark from urobilinogen, but bilirubin negative, stool is normal or dark, and LFTs are normal. In hepatic jaundice, you get a mixed picture with both fractions elevated, markedly elevated transaminases, dark urine from conjugated bilirubin, and variable stool color. In posthepatic jaundice, conjugated bilirubin rises, urine is dark and bilirubin positive, stool is pale, and alkaline phosphatase and GGT are markedly elevated. That 3-column table is the framework you need for every jaundice question on your shelf exam in Step 2. Thanks for watching. If this video helped you, please like, subscribe, and share it with a classmate. We've got more topics, explained videos coming your way, so hit that notification bell and we'll see you in the next one. References for this video include Harrison's Principles of Internal Medicine, 22nd edition, specifically Chapter 52 on Jaundice and Chapter 349 on the hyperbilirubinemias. Additional sources include recent reviews from pediatric research and the American Journal of Physiology, as well as the NASPGAN and ESPGAN joint guidelines on neonatal cholestasis.